Hi, this is Kelly Stacy. I'm out here in Rapid City, and I just want to say thank you for this talk. We are in the process of setting up CIN, and I'm trying to change our primary care to team-based model. And I have been snapping all your screenshots because this is exactly what I've been trying to tell people. I have quite a few of our executives who are in the process of helping us do this, but trying to show the middle management and the people who help with our salaries and stuff why this is important. So I want to say thank you. And this is exactly why I'm trying to do what I'm doing. So I appreciated it.
Well, Kelly, thank you so much for the work you're doing. It's much different, to try to implement this stuff on the ground in an operational way, as opposed to just espousing the kind of higher ideals of payment models.
Very true. I have two fluffy puppies I pet a lot at night because I'm ready to strangle half my team. So I I understand that one very much, but it helps because right now we have our VP over our like contracts and insurances and stuff. She's very much involved with me, helping me get the payment part of it, because that's always the problem is a lot of our physicians want to do this. They want the team-based care. They want to be able to take better care of patients, but it's always the billing, it's always the charges, it's how do you pay the physicians. And yet I have administrators who have budgets who say we have to do fee for service because it's more of a guaranteed, we know what we're doing. So trying to change the culture and change the minds has been quite fun and interesting. So it is extremely helpful. And so I did text Chris about getting your slides because there's a lot of this that is very similar to what I'm working on, but some of it's put together a little bit nicer than I have been able to do. So I appreciate that.
Thank you.
Mary Nelman, you're next.
Well, you had just asked if people have were somewhat older and had practiced under different systems. I remember when Medicare came in, I was working in my father's office. I was running his work and doing his documentation and things like that. I was a young teenager at the time. And boy, was he mad. He was really mad. They started off by saying, well, whatever you used to charge, we looked at that and we're going to give you 80%. Well, he was a rural doctor, rural family doc. It was $6 for an office visit. And somebody down the road who saw the same patient and had been charging 15 got a real bonus then. So he was livid. It was just not a good time to be around Dad. So I was just wondering how much pushback you're getting on the increased conversion, the increased RVUs for the primary care office visits. Because as you say, somebody had to lose with that. And how much pushback and what do you think the likelihood is that that's going to be stable?
So, that presentation and that work that we did before the RUC was really the culmination of many years of advocacy and working towards the goal of revaluing the E&M codes. And I will tell you that, and I didn't go into the drama of it all, but it was an absolute epic battle. It was probably the most epic battle of my professional career. And the ability for us, me and my co-presenters, to be able to get 2/3 of the RUC to go along with what everyone I think understood was necessary was a huge lift, and there was significant opposition mounted against our efforts. But we prevailed, and now it is essentially the law. I think the bigger headwinds we face at this point is that downward pressure on the conversion factor, as I talked about in one of my slides, that there's always going to be people jockeying for increase for new procedures that enter the fee schedule, for increases in some codes, and that's always going to put some kind of downward pressure on the conversion factor, and that's one of the headwinds that we face.
Thank you.
This is Rob Allison. So just a quick note here, and then I'll have a question for you, Bill. We're going to move Bob Doherty's talk to 12:35, just so people kind of have a reference. And then we'll probably go into the town hall meeting around 1:15. So try to give you a little bit of time off here. So if we get a few more questions here real quick. Bill, I'm a coding guru. Like you, I fight this as a private practitioner. This is not taught in medical school, and residents and none of these people understand the billing and coding, and that diagram with 3 different parts and complexity was just a nightmare. There was a recent article you and I talked about changing physician behaviors, And I don't think I'm doing a very good job yet either in regards to what I document. I think I'm still over documenting more than I need to. And I think that'll be interesting to kind of evaluate in regards to payment and what we need to do as physicians besides giving a good history and a plan. What can we do with the less work so we're not doing too much?
Yes, if I could just reflect back on that, I'll say I do think, one of the big portions of these changes is the simplified documentation, that you no longer have this check the box system or bullet code system. How many bullet points of physical exam are you doing? And that's a time saver, and time, of course, is money. So it's a big money saver, and it may there have been some estimates that documentation simplification is worth about $30,000 or more to the average physician. So this is still relatively new. Hopefully we're going to get there.
But Kelly, last question.
All right. Well, thanks, Dr. Fox. I would just add another layer to this. I'm a primary care internist also, and I work for a health system which changed over to an accountable care organization, an ACO, a year or two before the pandemic. So we haven't heard a lot about it just because all of those things kind of took a backseat. But I found that while working within a system that was going for a goal of an ACO, but still being paid on a fee-for-service model as a physician, there's some inherent conflict there. And I just wonder if you could comment on what you think the role and the future of ACOs might be.
Well, I think you raise a really good point, Kelly, because I think the transition is what's so tough. We're kind of in fee for service. We're in one place. We're trying to get to this other place. How do we cross the chasm? But I do think ACOs are playing a role, and I think they're going to be around for a while, and they have the opportunity to allow at least some hybrid payments or some quality payments along with fee for service, and the opportunity to participate in shared savings. So I do think they represent one way that we can cross that chasm. I personally participate in an accountable care organization. Relatively new to it, so I don't know yet 100% how well it will work out. But the ability to receive some payment to focus on quality instead of quantity, instead of volume, can be very helpful.
Well, thank you, Bill, for your talk. I'm going to kind of finish up here so we can get moving forward. I'd like to thank our moderator, Jennifer Williamson, for doing the morning session here. Bob is on. I can see him on. Bob, we're going to probably try to get you going about 12:35. So maybe take a 10-minute break here real quick. Everyone grab some food, microwave something, and we'll try to be back around that time. And then we'll sacrifice a little bit of the town hall to listen to Bob's great talk. So see you everybody in about 10 minutes.
Thank you.